right. Good morning, everyone, and welcome to our breakout session today, looking at women's leadership on the front lines of the pandemic and the pandemic response. I'm Vanessa Kerry. I am a physician by training and the founder and work at Mass General Hospital in Boston and Harvard Medical School. And I'm the founder and CEO of Seed Global Health, an organization that partners with governments to invest in health and well-being through the training of their healthcare workforce in order to create a path to overall prosperity and to better health. So it is a pleasure to welcome everyone this morning, and I have the really profound honor of being able to moderate what I think is going to be a really extraordinary panel and breakout session of leaders, extraordinary leaders that have been in each of their own way absolutely on the front lines of not just the COVID-19 pandemic, but I think on many of the health challenges that their countries, their colleagues and their patients and others have seen and experienced. So a few quick housekeeping things as we get started this morning. I want to remind everyone that this session will be recorded, which means that it'll be available on demand at the website, which is www.covid5050.org. So if you do want to look back at any of the content or you have to leave during the live session and you want to review the topics, this will be available. I want to encourage you to ask questions. Please use the Q&A function in Zoom to ask questions. We will have a period at the end of the session. I'm going to ask some questions of our panel, but then we will have a period for some Q&A at the end. When you do ask a question, please introduce yourself with your name, as well as maybe some context of where you're based or what you're doing as you ask your question. We want to raise the voice of this entire endeavor, of the voices of our panel, of your voices, of this work, of the need to really highlight, recognize, and celebrate women's leadership in this moment of COVID, in pandemics, insecurity, and the work that we are doing. And so we are going to encourage you, please, for those of you that are on social media, to use the designated hashtags that I will ask to be posted in the chat function now, to really highlight this conversation and to keep this conversation going subsequently, even after today. There will be a networking session after this panel from 12 until 1 Eastern Standard Daylight Time. And the links to that will be shared in the chat box as well. So we're very, very excited to be able to welcome you today and to be able to have this conversation. I do want to introduce our really extraordinary panel because we have a diversity of women who all have brought their strengths and their vision to bear. The first person I'd like to introduce today is Honorable Minister Dr. Magda Robalo, who's the High Commissioner for COVID-19 in the Office of the President in Guinea-Bissau. She is in charge of coordinating the national response to the pandemic in the country, and she's the immediate past Minister of Public Health in the first parity government of Guinea-Bissau. She is an adjunct professor at Griffith University, a member of the Malaria Elimination Aid Board, and the chair of the Ethics and Governance Committee of the Global Fund to fight AIDS, tuberculosis, and malaria. She's led an outstanding career of over 30 years in public health, and we are profoundly honored to welcome you today, so thank you. We also have Ambassador Stéphanie Seydoux, the Ambassador of Global Health for France. Stéphanie was appointed the French Ambassador for Global Health in May of 2018. She has served as the head of Women's Rights and Gender in the Equality Division, and she's assistant to the Director General of Women's Affairs and Social Cohesion from 2014 to 2017. Since November 2017, she has been in charge of the support mission to the government for the revision of the bioethics laws. We are also joined today by Ambassador Nora Kronig, Ambassador of Global Health for Switzerland. Nora has been the head of international affairs. She's the head of the International Affairs Division and the Vice Director General of the Federal Office of Public Health, as well as a Swiss Ambassador for Global Health. We have Ms. Mendin, who is the County Manager for Last Mile Health in Grand Bassa County in Liberia. Xavier is a registered nurse from Liberia. She's also a public health professional and an alum of the UCSF HEAL Initiative Fellowship. She holds a bachelor's in nursing from the Mother Pattern College of Health Sciences in Liberia and a master's in public health from the University of Liverpool in the United Kingdom. Xavier has worked as a Liberian healthcare system. It was worked in the Liberian healthcare system for over 12 years with various sectors, including the government, non-governmental agencies, and faith-based institutions. And finally, and very importantly, we are joined by Dr. Tsion, who is a doctor of emergency medicine and assistant professor at Columbia. She also serves as a special advisor to the Ministry of Health of Ethiopia on emergency care and strategic partnerships. And though born and raised in Ethiopia, she has been working on the front lines of the COVID-19 pandemic currently in Columbia and at Columbia University in New York, which we know the pandemic has been among the worst in the United States. So it is an honor for me to welcome everybody and to ask all of our panelists to reflect on a couple very key questions as we go forward. And really what I want all of you, as we engage in this conversation today, I want all of you please to help think, answer, and really illustrate all the ways in which you have been leaders in this moment of COVID-19. What have been those leadership moments that you have drawn on as you have been helping us as a world respond to this unprecedented moment, as well as your countries, your context, your families, all the front lines that you are working on in this moment. And you know, it's one that I think, you know, we should account for. One thing I didn't mention is I'm also a mother of 2 small children. And so for me, the front lines exist both from the global to the hospital to our families, and we are balancing all of these. And all of them are critically important to our security and to our well-being as a global community, as well as the communities in which we live in. So Magda, I would like to start with you, if it is all right. And I'd love to hear a little bit specifically about, you know, really what has been your experience leading the COVID-19 response in Guinea-Bissau. It's a country that is unfortunately fairly resource limited. And I think it would be very interesting to hear a little bit about how you've been able to help your country respond in this moment.
Thank you, Vanessa, for that question. I must say, first of all, that I'm truly honored to be part of this conversation this morning from you, but for me it's afternoon. I think I had quite an interesting experience with COVID-19 pandemic in Guinea-Bissau. I was the Minister of Health when COVID-19 struck. It wasn't yet a pandemic, but it was with me that the country started the preparations for confronting an eventual importation of cases and having the epidemic in Guinea-Bissau. And then we had an abrupt change of government and a new leadership was at the Ministry of Health. Guinea-Bissau, like you said, is a country with limited resources, but also it's a country with very fragile institutions, a very chronic social and political instability, which moved us into a very deep divided country. Either you are on one side of the political party that is in government, or you are on the opposite side. And the pandemic found us in this situation. We had elections in December, the 29th of December, and the issue of the elections weren't resolved until COVID-19 became a pandemic. The abrupt change of government meant that all the preparations that we had started came to a standstill until the new government came into place. Things were not so okay when then the president decided to institute the High Commission, and I was called to come and lead the response. What that meant was that I was coming from the government, which was at the moment no longer in power, and seen as the other side. And I had come to navigate the political divide that we are having, and which had a very negative impact on the way the population was seeing the pandemic. A state of emergency was established. There was a curfew. The borders were closed, and many people felt that this had nothing to do with the pandemic, but it was a political maneuvering. So I found myself in the middle of this, and my job, more than being a technical lead and concentrating on the strategies and the best way of dealing with the pandemic, was essentially political acumen, diplomacy, ability to navigate the opposing sides of the conflict, and being able to bring people together to trust what was being done, and through that being able to change some of the strategies and get people to move on, unite around what was being done, what needed to be done to lead to curtail the number of cases. And fortunately, we are now with 9 weeks where the number of cases are going down, but it continues to be a very challenging political maneuvering in a very small, tiny country. We had challenges with commodities, as you know. I think this was a problem, a worldwide problem, particularly for Africa, where, as you know, we don't produce masks, we don't produce the test kits, we don't produce none of the tools that were needed to do the diagnosis, and the PPEs that were needed. So with borders closed, it was a very challenging situation for us to get procurement and complex operations to bring humanitarian flights to deliver the commodities. So it has been quite an experience, but 36 hours a day, 11 days a week to navigate this. So I think I will stop here, but just to say the political partisanship has been really the most challenging part of handling a pandemic, which had also its complexities, because it's a unique moment that the world is living with lockdowns and all the consequences on the economy as well.
Well, congratulations on having such a consistent period with cases going down. I think that's really a remarkable achievement, that despite the political, some of the political challenges, that has been feasible, because, I mean, we're certainly not experiencing that necessarily here in the United States. So I appreciate that very much. I'd like to move on to actually ask Stéphanie about, how this has been, in France specifically, because France took specific measures early in the pandemic, for example, to address increases in domestic violence that were being suffered in lockdown, they're being suffered by women in lockdown by men. And certainly, I think this is very important, just to be that holistic and thinking about how do you protect vulnerable populations in this moment, and to recognize this particular one is quite thoughtful. I'd love if you could share a little bit about how that came about, what measures were taken, and what the success has been.
Thank you very much. Such an honor and such a pleasure to be in this on this event. I love women in global health, and I'm so in awe of what Magda's just told us, because I've seen her work as chair of the Ethics and Governance Committee of the Global Fund, on top of everything that she's been describing. And I am also so pleased to see my colleague Nora, and well, France and Switzerland are our neighbor countries, our very close partners, and there's been a lot of bilateral cooperation between our two countries in the last months, and so I take this opportunity to salute her. So to your question, indeed, well, very early on, as soon as lockdown was decided by the president mid-March, measures were taken by the government in order to mitigate as much as possible the risk that everyone could see of lockdown, and that had never happened before in our country, is same as in obviously all others, in the fear that this would well, cause terrible conditions for domestic violence against women and incidentally against children as well. So measures were taken from the onset, and I want to give credit straight away to the very strong feminist movements in France and civil society organizations who've been extremely vigilant about this. So what measures were taken? Well, a plan was announced in the few days following the announcement of the lockdown, with a big campaign to raise awareness and to give new tools. And so the new tools which were put forward were the following: new channels for victims to be able to signal cases without raising the attention of their spouses, for instance, going to the chemists, to pharmacies, or in supermarkets, for instance. So this was new. This was new. Also, we opened a new platform 24/7 for alerting either from victims or witnesses of violence, and this proved quite effective. We have a hotline which is more of a support than an emergency hotline, which was also reinforced and with obviously adjusted means to the lockdown. So with an increased number of respondents being able to work from home. Everything was done in order to ensure continuity in the judicial system, although courts were obviously closed also, so that there'd be no interruption in enforcement, for instance, of emergency measures to protect women from a violent spouse. And in France, the rule is that it is the spouse who is well, excluded from the home, and not the woman who has to leave the house, although in very many cases, as we know, this is still the reality. In that respect also, the number of emergency housing places was increased, and more money, well, €1 million was also increase was granted to civil society organizations. So all of that was put in place fairly quickly, and as I said, with this huge campaign.
And that was the civil society campaign? Sorry, that was the civil society campaign that went forward? That was a government-led campaign?
It was a government campaign, but it was also with a lot of help from also, well, there were brands contributing to this, and it was relayed through social media in a very open way. So it was quite an effective campaign, and actually, so I think your next question, Vanessa, is going to be about results and whether there's anything we can say about how this rolled out. Now, obviously, not easy to say yet, but we do have a report dated end of July, so quite soon after all this was put in place. The lockdown ended mid-May. And well, we now have partial measures of confinement, but it's not the same as the situation which we went through for about 2.5 months. So what this report says, which is a government report based on official numbers and analysis, as well as more qualitative feedback from professionals active in protection of women. They can't say that the lockdown triggered more violence. What they have noticed that there's been much more many more requests for help, and so let me just check, between the 16th of March, beginning of the lockdown, and the 10th of May, which is the end of the lockdown, they had about 45,000 calls on the hotline, which is more than twice the usual number. And so their analysis so far is that the effect of the lockdown, which was more to well, basically make the situation more acute. Also, they think the effect of the campaign was that, well, means were being offered, and in some cases, apparently cases were signaled before they got to the, unfortunately, usual extreme point, and victims were able to be taken care of earlier on in the process. So this is a provisional analysis of the situation and will necessarily have to be followed up by a more in-depth analysis. We still have in France an excessively high number of victims of violence, including women killed by their spouses. So certainly not out of the woods yet, but it's an interesting provisional conclusion. And just to follow up, there were also measures to enable women, this is a different issue, but to ensure continuity and act to sexual and reproductive rights, with measures such as the allowing women to renew their prescription for abortive pills, contraceptive pills, without necessarily having to go get a new prescription, and also measures to accept requests for abortion, not necessarily with a strict application of the legal time limit. So this was also put in place. And finally, just to say that France at the multilateral level was active, joining all multilateral initiatives which were promoting gender equality and protection of women during the COVID crisis, such as the April 2020 joint statement, which was joined by 50 countries for the protection of sexual and reproductive health and rights, and for the promotion of gender responsiveness in the crisis. And finally, but we might talk about this later, we have remained very active with our partners, with UN Women in Mexico, in the preparation of the Generation Equality Forum, which will take place in July 2021, which should have taken place in Paris and should have taken place last July. This is what I can say.
Thank you. I mean, it's amazing to see how France has really stepped into this moment to ensure and to be thoughtful about these, you know, how to create certain protections and vulnerabilities. And I think it's actually a terrific segue to your neighbor in Switzerland, and would like to ask Nora actually to comment, if you could, about how Switzerland has taken any measures in COVID-19 to protect women and their employment, since women are typically been the first to lose their jobs. And so, or to make, you know, to have to address the family needs in this very unusual moment. And so it would be terrific to hear from you about your experience in leadership in COVID-19, as well as sort of the measures Switzerland has taken to protect women economically in this moment.
Thank you, Vanessa, and hello to all of you. Also a greeting from my part on the neighboring France, and also on all the colleagues who are joining the discussion today. I have to say that after 6 months of pandemics, I suffer more and more on just only being able to meet virtually. I do find that we lose all the possibilities on the side. But nonetheless, it gives us also the possibility to have a truly global exchange very often. And I feel that we have the possibility to talk to each other on a daily basis, near or far. And then interestingly enough, I think that global cooperation has never been so intense as it has been in the last months to solve problems together. I maybe first want to tackle what we've done at mid-crisis, so to say. We do have a scientific task force that was put up to help us get the right knowledge about how to deal with the virus, and worked on a lot of different components. And they've done a study specifically on gender aspects of COVID-19 and on pandemic response regarding those dimensions. And why am I mentioning the study? Because they really point out 5 points that for Switzerland have been important in terms of gender and COVID-19 pandemic. But that I do feel, having heard the two colleagues before, that help us also have a reflection generally about the different topics of inequality that we have to look into. First, and I mean, you've just said it, a woman have more precarious economical situations. I think in the whole world, in Switzerland it's the case. They tend to lose jobs easier, but they're also less stable in the labor market. Second, and Stéphanie talked about that, I think that the fact that gender-based violence increases in crisis is a known fact. And it certainly is something that we followed in Switzerland as well. Interestingly enough, in terms of results, we don't have any evidence yet that domestic violence has increased during the pandemic, but we put up a lot of effort with campaigns, with information to the population, with hotlines, and I think that the distress of people were helping everybody independently of being man or woman, but also for different backgrounds and different parts of the population, and I think it was really key to accompany the way to get over the crisis. Thirdly, I think one interesting point that came out was the exposure of women in the health sector to critical patients, which is something that I feel we tend to forget a little bit. The health sector labor force is a majority of composed by women, and meaning that they also the ones who are not just giving care, but the most exposed one to the virus in the ICUs and towards the cases that are more severe. Fourth, we've have had a look at the sexual and reproductive health services. We've had that for other dimensions as well, but we had quite a lot of trouble of, for example, cancer care, where people would tend during the lockdown to use services less, go less to the hospitals. I'd also serious concern about children's health, because parents would tend to be a bit scared to go to the hospital. And I think that we don't talk enough about what it means for different topics like abortion in times of lockdown and crisis. How do you deal with that when you're not able to get to the services anyhow? And then fifth but not last, I think that migrant women, what it means for domestic workers who are essentially composed by women, is certainly a dimension that we will, I hope, get more knowledge about once the pandemic is over. So coming back to your question on the actions, the question is always, okay, the situation is there. I think we all know about it, or at least have a sense that there should be challenges on those dimensions. Questions is, what do we do? How do we act? And I don't want to be too long. I will not go into the different topics, but I just wanted to flag them because I find it quite interesting for the discussion. But regarding labor market possibilities, we are a very liberal country. We do have a very thriving private sector, and we tend to regulate as a state as little as possible, and the public sector is only intervening when there is a necessity for it. We've done a lot in terms of helping the companies to get to liquidities, and we've taken very strong fiscal measures, meaning that the federal government used in 3 months what we had saved up for 10 years in order for the economy to recover, in terms of being able for the companies not having to fail down or to shut, helping them going into part-time labor, investing quite a lot in our unemployment insurance for schemes to be put up in order for at least a temporary build on, so that we wouldn't lose either companies or people just going into financial distress. And also worked on the procedures of how to get to unemployment, how to facilitate and to have this kind of measures. It worked really well. I think that also in terms of economical dimensions at the moment, we probably managing as well as we can. I think we have to be mindful of what comes now. The financial crisis is only starting. The consequences are only starting. We still don't know what we have ahead of us. And to go back to a situation like in Guinea-Bissau, I don't even know how we will cope with all the political tensions that might arise, given the complicated situation to come. So thank you. I will stop here, and I'm really looking forward to the discussion. Thanks again for having invited me to participate today. Thank you.
Thank you so much for just that incredible overview. It's quite extraordinary to hear what very, very proactive and aggressive measures were taken, but that I'm sure did help to protect an extraordinary amount of jobs. I appreciated your noting that women make up a huge amount of the healthcare workforce, because I think that is very, very true. And one of our questions that we'll get to a little bit from the audience, actually, we'll talk about that as well. But I would like to ask Firew actually to speak. She has been involved in a lot of the healthcare response in Liberia, which has been very proactive about placing community health workers on the front lines of the various pandemic responses that they've unfortunately had to deal with in recent time. And certainly certainly there are lessons to be learned through those pandemics, whether it was Ebola in 2014, or if it is been, what we're dealing with in COVID-19 now. And so would be very, very interested to hear from Firew about your experience in leadership right now in COVID-19, as well as some of the lessons that have been learned from Ebola that have allowed more resilience in the face of COVID.
Thank you so much. And it's an honor to be here on this panel today, speaking with all these wonderful world leaders. I'm very humble. I'm speaking from Liberia, so greetings from Liberia. In terms of lessons we learned, I think we've learned a lot of lessons from the Ebola outbreak, from my work during the Ebola outbreak, and the current COVID-19 outbreak. But I will talk about three of the major ones. For the first lesson, during the Ebola outbreak, we learned that outbreaks in general begin in blind spots, in remote and rural communities. And in Liberia, we have a lot of remote and rural communities. It is estimated that about 1.2 million of our population live outside the reach of any healthcare facility. So when the Ebola crisis struck, we saw community health workers stepping up to serve these rural communities that would have otherwise been cut off from the healthcare system because they are far beyond the reach of the formal healthcare system. And so they stepped up and they demonstrated that they are an important member of an integrated primary healthcare system. And they also show that when they are fully supported, they can contribute to building an equitable and more responsive healthcare system. So against that background, after the 2014 outbreak, the government invested in a national community health worker program and invested in having one community health worker in every remote village in Liberia. To that end, we've scaled up the program to about 70% of the country. And these community health workers are trained and they are supervised by a nurse like me. And they work in this remote community to provide primary healthcare services. So based upon our lesson learned, when the coronavirus struck, these same community health workers step up and they are also in the front lines, supporting the crisis. That's one of the key lessons we learned and how we apply it to help us cope with this crisis. The next one had to do with the fact that in the face of outbreaks, there are lack of access to routine healthcare services. And that lack of access, we came to realize that it can cause more death even than the pandemic itself. And so with that, when the pandemic struck, we went strictly work with the government and we started training for healthcare workers, especially community health workers. They were trained in infection prevention and control protocols, using updated tools and curriculums, integrating the COVID response information. And we continue to work with the government to mobilize resources to have personal protective equipment for these healthcare workers, including our community health workers who are in the front lines, helping to combat the coronavirus, as well as continuing routine service delivery. And we also learned a third lesson too, when we had the previous outbreak. We saw that men and women experience different, they have different experience during outbreaks. And women are disproportionately affected. We see that their increased caregiving responsibility will double during these times. They continue to provide increased informal care. It's an added burden. They also lack access to most of the reproductive health care services. During the Ebola, by far the biggest driver of maternal mortality was that women were giving birth at home, and they were not assisted by medical practitioners because the healthcare system was overwhelmed. So that is one of the key things. And we also see that women, the economic crisis also is higher for them. In Liberia, during the Ebola crisis, the unemployment rate tripled. It was high for both men and women. It was insane. But still, the researchers found later that men were able to recover quicker, and it took longer time for women to recover. So in terms of this third lesson, we still see challenges are still present. We are very lucky to have a female minister of health, but at the local level where I work, there are still challenges. Challenges still persist. And if most of the high level meetings, I am one of the few women attending these meetings. Where are the other talents? Where are the other women who are supposed to be there to also bring about these ideas and all the innovations that can help to have more impact? So these are some of the challenges we see. Even our community health workforce in Liberia, about an estimated 20% are female, the other 80 are male. So we've also looked at that as a challenge, and we continue to work with the Ministry of Health to see how we can also review our recruitment strategies to ensure that we can promote a more gender balanced community health workforce. So these are the lessons we learned, and these are some of the things that we applied to be able to cope with the coronavirus crisis. We know there are other areas that we can still grow, we can still build upon, but we'd like to stop here for now.
Thank you so much. It's a really powerful testimonial to what can be both accomplished as well as what the challenges remain. And we are, again, I don't mean to keep punting this down the line, but the question that I'm going to have you all pose is on some of those existing challenges still. You know, you really outline the power and importance, obviously, of reach and of essential services and primary care. And I want to turn for a moment to, you know, my home country of the United States to talk about the epidemic here and what it is meant to be on the front lines of the epidemic here. And, you know, Tsion, you've been in the emergency room in New York, one of the hardest hit areas in the United States. Got hit early, badly, resource overwhelmed, many inequities played out in New York City because of the concentration of people, the density, the poverty, the essential workers, a number of things that were playing out that you saw firsthand through your work. And I was wondering if you could please, as you talk about your own experience in leadership in this moment, and you wear two hats. So I also welcome hearing about sort of, you know, maybe where Ethiopia has gotten it right, especially with its commitment to gender parity. But, you know, what can you tell us about the impact of inequality and COVID-19 in the United States? And, you know, if we'd had a more universal health coverage system, if we had a different way of investing in our healthcare here, do you think we would have had different outcomes? What were the moments you saw that frankly were frustrating? I mean, I know from my experience in the ICU, I was overwhelmed at times by things that felt very preventable. And I'd love to hear your perspective.
Thank you, Vanessa, for that question. And also, before I start, I also want to mention how I'm honored to be here, especially amongst this highly achieved and accomplished women here. And I also want to appreciate all the efforts that have been performed and all the ongoing efforts by the Women in Global Health. Just like you said, I worked in one of the highest impacted area in New York, specifically the zip code actually, where I worked in. Columbia was one of the hardest hit area, and also we served a very diverse population. Unfortunately, like the data has shown us, Black and Hispanic patients died disproportionately due to COVID-19. And we're learning it's not because of genetics or their race, but really because of poor access to health. And this is just a universal issue all over America. And what we've seen in New York, most Black and Hispanic patients lived near hospitals that were either crowded, overwhelmed, or overwhelmed by the system. And especially women and minorities were faced with the triple burden because they lived mostly in a multi-generation family where they'd have to take care of their kids. They also have to take care of their parents, and they delayed their own care. Most of the women patients that came to my emergency department, they waited until the last minute. And when you ask why, I had to take care of the kids who were not at school anymore. I had to take care of my parents or their parents at other hospitals. So really that selflessness that came with that, and really prioritize others people's health instead of their own health. And also because of the constrained resources that we witnessed just all over, people of color, just like I said, women, people with lower socioeconomic status in the US suffer disproportionately. And unfortunately, your zip code determines whether you live, whether you die. And we've seen this in New York. Some zip codes had higher mortality rates, double mortality rates that we've seen in some of the zip codes. And personally, I feel like it was my personal responsibility, just like you said, because media was not allowed. People did not see what was inside the hospital, and it just felt personal responsibility to teach with an evidence base in what we're seeing to the general population, because as you've seen, a lot of misconceptions, a lot of what we call fake news was kind of just spreading around through different social media outlets. And me and my colleagues, we made it our personal responsibility to go teach the community about the disparities that we were seeing. And what we were seeing, we were just serving as the public, as the eyes for the public, because people didn't understand what was happening behind the hospitals, and they were just told to stay at the hospital. Of course, the question of if we had universal health coverage, could we have averted all the deaths and the disability because of COVID-19? Absolutely, yes. We've seen that people with access to healthcare had better outcomes, and some uninsured patients came a lot later. Meanwhile, while those, the ones that had access to care, either reached out to their own providers through telehealth, because most of the primary healthcare institutions, as we know, were closed due to COVID-19 until people figured out how they can continue and how they can provide care. And as you said, New York was the hardest hit area way early on, before we were prepared, before we had all the evidences coming from Italy and China. So we're kind of learning as we were going through it in person. And even though we're still in the middle of the pandemic and the US being one of the hardest hit areas, I'm worried about not only about what's happening now, but what I call the aftermath, or the after COVID math, because due to economic issues and loss of job, we're seeing patients are losing their health insurance, which because of no universal health coverage in this country, that is going to be an issue going forward. I'm seeing a lot of patients not affording their diabetes medication because they can't pay for it anymore, or because they lost their insurance, which is an issue that only happens in the USA because it's dependent upon their employment. And because of that, they can't afford their primary care and using the emergency department late due to complication of their chronic diseases. And we needed universal health coverage before this pandemic, and absolutely it will be very important that we address the increasing health access to everyone, especially in the US after the pandemic. And we're going to see the disparities, and of course, disproportionately, they're again affecting women and also the minorities. And of course, I can't really finish without talking about what we witnessed in the US. And when I was working in New York, I remember just because public transportation was closed and because I needed time to reflect, I used to walk home. And most of it, at the end of my shift, I walked home thinking that this is going to ravage through Ethiopia and to other sub-Saharan African countries. How are we going to survive it? Meaning this was very early. And fortunately, even with the numbers that are increasing in Ethiopia, the way we've handled the mortality is not as bad and as severe what we've seen in the US, while there are so many theories that I can't get into right now. But looking at the leadership representation in Ethiopia, we have a woman health minister that was appointed the day after the first case of COVID. And in the past few months, we've seen more women appointed at the regional head bureau. And 3 weeks ago, we had another state minister, deputy minister that was appointed that was women. So at the very top leadership in Ethiopia, the 3/4 of the top leadership at the health ministry is dominated by women. But unfortunately, that doesn't translate down, because when you go to the regional bureaus, the hospital leadership, even when I've had the opportunity to go back and continue my work after July, you go to the COVID task force and over 80-90% of the task force members are men. And of course, translating that to the US, and you've seen most of the White House task force is male, and you see Dr. Briggs here and then, but also the health commissioners from New York, California, Ohio, who were doing such a great job leading it. They were forced to resign because either their family members were threatened, or they were threatened personally because they were trying to use evidence and to use and to suggest universal masking. So in both countries, there's still a long way to go to achieving gender equity, especially in leadership position. It's not really a matter of putting women at the center of the table, but it's really heeding their advice and supporting them. And we need our allies to support. That includes the men and everyone to support the leadership and to continue that we recruit women to this top leadership. And also that when women are in power, they're going to take more likely a collaborative effort and also include other women to be as part of the leadership.
I want to follow up on that actually, because we got a question from Katie Cowie, who is a medical student at St. George's University of London and the president of her university's Global Health Society. And she asked specifically that, how is it that in the UK, medical students are predominantly female and most global health societies are led by female students? But in this pandemic, the representatives of government and health that we have seen are often most frequently men. And why does this seem to always happen? And she's asking specifically in the UK, but I think to your point, this is a phenomenon that this is what we're trying to change in part, right? When you look at leadership around the world and some of the countries that have been the most proactive in their response to COVID, whether it was New Zealand or Finland, we're hearing about France and Switzerland, places that have been able to really lean in are being led by female-led responses. And there's actually data that shows those countries have potentially done better. But how do we start to change this paradigm? I'd like to hear from our panelists about this, because I think that is the crux of this. We have so much wisdom, experience, and ways of really, I think, embracing the complexity of these challenges in a way that is holistic, thoughtful, gets to the social determinants of health, and gets us farther in our response. But how do we change this paradigm? Anyone on the panel? Magda, you leaning in? Go for it.
Yes, I may. I can start. I think we have a long way to go. There is no doubt. What we get out is what we put in. If we are seeing very few women leading through this pandemic, it's because they were not leading before the pandemic. So the pre-pandemic leadership by women, we know the causes, we know the consequences. I think going forward, after the pandemic it's going to be a new day in all fronts, economic, cultural, social, etc. I think we have an opportunity to let the Build Back Better, to come up with policies that will, particularly on the economic front, cater for women. In my country, the women were the hardest. It's like in most countries, if not all, because they are the ones who actually provide for the families with the informal work, selling tomatoes, selling fruits, selling peanuts, doing household work, etc. And we need to look for ways and means of empowering these women so that they have better jobs, they have better revenues, and they can lift themselves out of poverty. Unless they continue, unless that happens, you will never see women leading. They will still busy with sending the children to school, so they have to work hard to pay the school fees. They have to work hard to pay for medication, and they will never have the opportunity to be sitting around the table, to read a book and prepare for that meeting where they can make a difference and be seen, be considered, and be given the respect they deserve. So building back better, I think economic policies need to be really shaped in ways and means that women benefit. We need to look at the impact on education. Many women, many teenagers, many young girls will not go back to school because right now they are either married or about to marry. Many have become pregnant, and issue of data here is important. I was listening to Tsion, and she could relate the zip codes with the consequences on the population in where they live. I can't do that because we just don't have the data to pinpoint what is happening, and that's also important. We need to improve on data as we work towards improving our surveillance here. We are building a technology mechanism so that we can really collect data from the remotest areas and have it in distributed to and shared with everyone the same day as it is happening. And my dream is not to lose this after the pandemic, to be able to continue having the data we need so that we can locate the problem. As I am concerned with who's dying, why are they dying, who's infected, why are they infected? I want to be able to gather those data for other things so that we can improve on the conditions and the leadership of women across Guinea-Bissau and across the world.
Thank you for that. I think the one thing I'd add as well, and somebody has commented on this, also is the challenge of childcare, right? Is how that fits into the ability to allow women to be able to engage in their work meaningfully, but also be able to ensure their family is cared for, and would sort of add that to the list with the education, with the economics, with all of these pieces. You know, this is the pain of really outstanding panelists, is that you all have extraordinary things to say, and we come up on the end of an hour very quickly. So I actually want to ask each of our panelists, we are going to have a networking event after this. I'd like each of our panelists who have not yet spoken or given some thoughts on the women leadership piece to maybe give us some quick concluding thoughts to kind of highlight how do we start to change this paradigm and have a continuity of your leadership and your visions to be carried on through next generations and to grow in this generation and so on. So Stéphanie, if I could ask you to give some closing thoughts as well.
Well, thank you so much. Yes, things must change, and completely agree with everything that Magda said, and indeed very impressed by the testimonies that we've had earlier on the panel. If I had to choose one lever in order to move forward to get better leadership, it has to be quotas. And it has to be enforcement of something which, of course, we'd all prefer to not have to resort to, but quotas, basically, of women in leading positions and women all along the way in the decision making. And it's easy to count women and men, huh? Only two groups. Indeed, you need data to do that, but can be done. And just one hope is, or one suggestion, one lever which I believe is super important is to, especially post-COVID, invest in a gender equal health force. And I think that addresses so many issues. There's been talk of a triple dividend. Women who work in healthcare get paid better. Dividend for gender equality, dividend for health, quality of health, and dividend for economic growth. So this is, we've not seen the end of that. I know that Women in Global Health has been very active in this area, and my friend Rupa is on the call, I think, and really, really interested in moving this forward, possibly at the Generation Equality Forum. And in this respect, I really embrace the 5 asks that Women in Global Health have put forward, and I'm very happy to commit to sponsoring them within my government and overall.
It's terrific. Thank you for that. That is really extraordinary. Thank you. Nora.
Thank you. I did personally find that the whole pandemic has brought up 2 basic human qualities that I think are essential. Generosity and courage. And I do find that it was something that that accompanied me the whole time. And interestingly enough, and I don't know if I should say it in such a discussion, but I did find that in times of crisis, you also have to be able to deal with emotions. And interestingly enough, I think that the women have probably more possibilities to do so because the range of ways that you can show emotions is probably broader than what is allowed in a society that is too manly oriented. I don't have a last message. I have one wish. I think that what we have to aim for is no discrimination and not having to talk about how to make women more powerful or have more women leaders or whatever. I think we will have gotten there when we don't have to talk about it anymore. So I wish that we will be able to come out of the pandemic with less discrimination, more generosity, and more courage.
Thank you. And I would second the fact that we have an emotional range, which I think is actually critically important. It's part of our power and something I think that we should embrace and lean into. But Xavier, we would love some thoughts from you about how we start to change these paradigms.
Thank you, Vanessa. I think for us, I will talk about my profession as a nurse. In Liberia, the nursing profession is like a very gender one. It's mostly where you have more women. And most times due to the limited capacity building opportunities and leadership development opportunities, it takes time to excel. So mostly women are in that segregated role, mostly down there, and it takes time because of those opportunities. So I would say for this, I think governments need to look at this as an economic development agenda. Look to governments to put it in their economic agenda to see how leadership development can be highlighted for women, because it's not just calling you to the table, but setting you up with the tools and the resources to be able to advance. So that is very important. And even our community health workforce cadre, to see how as people we can create clear career pathways for them too, so they can be able to excel and not just remain in like as household caregivers. So those are closing thoughts I want to share.
Thank you. And last but not least, do you want to
I think I've said everything, and it's very hard to follow all the great things that's been said. But just like I said earlier, just to reiterate what I said, it's not only about putting the women in power, but it's inviting them to the decision table. And it's important that men and women, all of us, rally behind them, support them, and also promote them. And this is also something I'd like to challenge our male colleagues, because they really do mean that they're all for gender equity. They need to walk the talk and continue to bring the gender agenda on all discussions. I've made it a habit when I walk into a room, I ask, where are the women? Where are the people of color? So it's very important that whatever privilege that we have, to use that to advocate. I do that here in the US, I do that in Ethiopia, and it's always making the ones in the room uncomfortable, and for them to think about us. Next time I walk into a room, like, oh, here she comes again, we have to make sure that we have a very diverse women in the room. So it's very important that we use the little voice that we have, or the big voices that people have in this room, to advocate. Yes. Thank you.
Thank you to this panel. And I think that, you know, what you've all highlighted importantly also is accountability. And I want to thank Women in Global Health and all of those that are sponsoring today to help us, that are helping us to create those metrics of accountability and that conversation towards accountability, and to march us on this path forward to create the kind of change that we need, because you are absolutely right. It is only by asking, by highlighting, and by not being silent anymore, but by really bringing this into our forefront, are we going to be able to create the kind of change that we seek, and we should seek, because we all benefit from it. This is about well-being. This is about caring for people. This is about being a global community on which we are all connected and all able to have a voice. And this panel has been an extraordinary group to really highlight, I think, the ability to create change, to be advocates, to be compassionate, to be smart, and to be agile in an incredibly difficult time. And we are all connected in this moment. And I want to thank you all for reminding us of that. We are a little bit over time, and I thank everybody for listening today. I do want to really encourage you to go to the networking sessions after this breakout. The link to the sessions is available in the chat box. I'm incredibly sorry we didn't get to everybody's questions. But please continue to follow the COVID 50/50 campaign, which is available on the website, covid5050.org, and continue to use your voice, continue to be out there, continue to lead in this moment, because it's unprecedented and we need absolutely every single one of you. Thank you very much.
Thank you. Let's go make them uncomfortable. Thank you.
Thank you.